Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our guest this evening is Dr. Sandy Ruhs. Welcome, Sandy.
Oh, thank you. It's a pleasure to be here.
Dr. Ruhs is the head of women's imaging at MercyOne in Des Moines and a colleague of mine, and we've spent many years working together.
Yes, yeah. I've been part of Mercy since 2001, so
Okay.
20 some years.
So we're going to talk about breast imaging, but before we talk about breast imaging, let's just get to know you a little bit. Where did you grow up?
I am from Iowa, so I'm an Iowa native, Eastern Iowa. Went to high school in Mount Vernon, but grew up on a farm outside of Mount Vernon, so farm girl.
Okay. And how big was your high school class in Mount Vernon?
About 101.
And what was your claim to fame in high school?
I'm not sure I had a claim to fame, other than it.
Sports, music,
yeah, it's like marching
theater,
band.
Marching band. What'd you play?
Flute and piccolo.
Okay. And then where did you go to college?
Went to college 1 year at Iowa State and played in their marching band, but then went into Iowa because obviously it's more medically related.
So when you went to Iowa State, did you think, were you already planning on going into medicine?
Oh, absolutely not. It was much more of a science field at that point. I enjoyed agronomy and botany, and so was in the sciences and math, but not into medicine.
And then what happened that first year that changed the trajectory of your profession?
Well, drastically, I ended up getting married and having a kid, and then needed a true career. And so Iowa had a med tech degree, which was a 4-year total degree, and you would then work in the lab afterwards. So I did that, and then worked for 4 years for University of Iowa, and got bored. So I went back to school, or applied to med school and got in, and it's like, here where I am now.
I didn't know that. And then how did you decide on radiology?
Radiology was more of just a process of elimination. I enjoyed a lot of the rotations that I went through. And with radiology, I'm able to still keep part in majority of those departments. And then it had just a specialized kind of focus to it. So I was able to continue in that. And then I went to WashU for fellowship, applied to 8 or 10 different residency programs. And I got into probably arguably the best that I know of in radiology at WashU and Mallinckrodt in St. Louis. So it's like, we're going there.
And when did you finish your training in radiology?
I finished, I was 94 through 98.
Okay.
And then my daughter at that point was in high school, and I stayed on as staff for WashU for almost 4 years while she finished high school. And before I kind of decided, where do we want to go now? And Iowa was calling us back. So
good. Well, we're fortunate that
it has happened that
so
way.
You grew up on a farm. Do you have anybody else in the medical field in your family?
Afterwards, I now have some nieces that have gone into nursing.
Okay.
So yes, but my background was no. My mother was secretarial. My father was a farmer and rural postal carrier. Mm-hmm.
I'm the first in my family to go to college and the first in medicine. So it's kind of changes the whole family dynamics.
It does. Mm-hmm. Although by the same token, neither of my kids went into medicine or anywhere. They're both engineers, but that's also in my background. I've got multiple brothers that are into the technical aspects of engineering.
Well, let's talk about breast imaging. And I thought maybe we'd start off first talking about the concept of screening mammography and kind of what does it mean to have a screening mammogram, and talk about that. And then we'll kind of maybe go through some scenarios where the screening mammogram doesn't turn out to be normal.
Yes. And the screening mammogram started decades ago, as far as it was used originally, that they but very different dose, very different technique. It started out with 0 mammograms, which are really beautiful, but they're fairly high radiation. So that was used 60s and 70s. After that point, it got into film screen mammography, which is much more sensitive. It's related to the emulsion that's used on the X-ray film, which are beautiful images. And obviously since it's evolved to be digital. So everything's acquired now in an analog manner and transmitted electronically to high resolution monitors, not your home style. It's got 5,000 megapixels per line resolution. So it's very high detail. And then just probably a dozen years ago, 3D came into being, which is not just a 2D mammogram that we're getting one picture. We can now actually slice through the breast and uncover or at least unravel some of the breast tissue to see through it. So that's been a huge advantage.
And with the 3D mammograms, what would you guess the number of, if you were to compare it to slices? Like how many slices?
They're allowed to go up to, because of the thickness of the breast, they're allowed up to 110 images. Most are around 40 to 60.
So instead of just one image of the breast for the whole thickness,
this
allows you to do a few millimeters of
thickness, and they're by 1 millimeter intervals.
1 millimeter intervals.
Okay. Yes, and that's the number for each projection, and each screening mammogram has 2 images per each breast.
Okay. And so even the concept of screening, so as we know, screening mammograms are done on people who do not have cancer or do not currently have cancer and do not have symptoms of cancer.
Correct.
So if a woman feels a lump and says, I need a mammogram, and the doctor orders one, that's not a screening mammogram. Correct.
And there's multiple questions before the woman gets to that point, whether the doctor felt it or she had felt something different. And that includes a lump, pain, dimpling, skin changes, nipple changes. So variety of things that's not always obvious that this is something bad, but it's something different, and let's work it up.
So back to the screening. So women, the older they get, the more likely they are to have breast cancer. Mm-hmm. We don't screen every woman right at the time that they start developing breasts. Maybe talk a little bit about the guidelines for which women should get screened at what age.
Yeah, so the incidence of breast cancer obviously does increase with the age, and it starts out pretty much as a flat line in the tens. Or teens and 20s. 30s, it starts to ramp up, and 40s, it has a pretty good incline on the rate of breast cancer that's prevalent in an average population. So in our ACR, American College of Radiology guidelines, it's always been age of 40 was the first time you started a mammogram, because was the kind of the highest or the uptick in the slope
for average risk
average risk patients. Mm-hmm. Since that point, we've obviously broken down into above risk patients. Many of that is family history of breast cancer. That used to be our sole guideline, but now there are so many genetic markers that also are genetic tests that can detect, a PAL-B, a CHEK2 mutation, any of these mutations, which increases the risk of breast cancer. And then you start earlier, up to or as low as age 30 at that point, to annual screening mammogram. That's if they don't have symptoms.
And typically when a woman, and a woman can actually order their own screening mammograms, right?
Absolutely. The screening
mammogram. One of the very few medical tests that a patient can order for themselves.
Order for yourself and just show up. You don't even need to have a primary care physician. It is helpful just in case there's something wrong and we kind of need to work through the next steps. Mm-hmm. But the first step on a screening does not necessarily even need a primary care physician.
And a screening mammogram doesn't require that a physician be present in the room or in the facility at the time that the mammograms being done, and they don't necessarily get looked at that very same day.
Yes, the screening mammograms are acquired by a technologist that is proficient. They've gone through so many kind of training mammograms to get proficient at that, and they acquire the standard images, sometimes extra ones depending on the body size and depending on how much coverage they get to kind of repeat or improve positioning. But from there, it's optimal to have the greatest concentration by me, the radiologist, if I can batch read them. I'm not interrupted. My attention is solely on interpreting for breast cancer. If I'm interrupted doing procedure, something else, yeah, it gets a little bit chaotic. So we
when you
batch
sit
read them
down
the next day.
Okay. And when you sit down to read screening mammograms, how many screening mammograms might you read, look at, and give interpretations of in one sitting in one day?
Yeah. And in one sitting, I try to do, like 15, 20 in one sitting, and then take an eye break. That's usually about an hour worth of them. And I read usually between diagnostics total. So screenings, probably around 75 or 80 screenings in any given shift.
Wow.
And then, yeah.
And so now with artificial intelligence or computer that's been around for a while. So obviously you've got your eyeballs and they're very good, but I would imagine, like my eyeballs, as we get older, vision isn't as good. I mean, you're wearing glasses. What do you see the role of computer-assisted reading or aiding in reading mammograms now, and do you see that that's going to play a bigger role as we get bigger, faster computers?
Yes. Computer aided detection has assisted us in detecting some things that the computer finds in its early phases, and it's been around for 20 years. It's detected way more artifact than true findings. And so then it's distracting because I have to rule out that these 10 different lesions in this breast are not significant and it is normal. They are evolving into a 3D mammogram. It's really good at detecting calcifications and architectural distortion. The other things that are abnormal are developing asymmetries, which just looks like a vague attenuation, or masses. CAD's not very good at detecting those yet. That still requires looking and comparing over previous mammograms to show that there's a change. So my best advantage is previous mammograms.
Right. So when you're looking at the very first mammogram that a patient's ever had, and you obviously have nothing to compare to.
Yes, we try to go with symmetry, but not everybody's built symmetric. Many of us aren't. So go with symmetry. Calcifications often, the first mammogram often has a higher callback rate so that they come back for these extra views to say, is this a normal finding? Is this not?
And so if a woman is, first of all, what percentage of mammograms are flagged as being abnormal in some way, shape, or form?
Our standards are up to about 10% can be called back. You get better with experience, and my group of radiologists have, don't even know combined years of, but our rate is usually around 5 to 7% callback. So we have a better ratio.
And then what percent of the patients who are called back actually end up having cancer?
Probably up to about 10% of those callback patients will need a procedure to rule out whether this is cancer. And of those, only about 30% of those will have cancer. So it's gone down.
It's more like 95% will not
98%
have cancer.
probably
will not have cancer. So that's good to know, so that women who get the call back, of course, I can only imagine what it's like when you get the call, you've got to come back. We need to do some extra views, and you're probably planning your funeral on the way back to get the
first
next
time anyone's
mammogram.
Called back, they are already starting to plan who
what to do. But the truth is 98% of those that are called back will not have cancer. So when a woman is called back, what's the additional imaging? And at this point, we call it now diagnostic imaging.
rather than screen.
And so a radiologist will be present and looking at their images while they're getting them done.
Correct. There's somewhat of a standard protocol depending on what they're being called back for. Calcifications will require magnification views. The other asymmetries or masses require sometimes ultrasound first, but they are the same mammograms, but they're more directed for the current problem. So they're spot views or they're different positioning, and definitely ultrasound is an adjunct to mammography. You wouldn't do one all by itself. They actually kind of aid each other.
Sometimes there might be some compression that you do on an area
Correct.
of asymmetry to see if it.
Yeah. So if we'd use a spot, whereas the full paddles, good rectangle. The spot paddle is probably only about 10 centimeters at max. So you're putting much more pressure that if it is real breast tissue, it just spreads out. Speculation would kind of even more accentuate. So you'd see the angular margins or the spider-like look if it was that.
So in this situation, we've had a woman that had a screening mammogram. She was called back, had an ultrasound and some close views, and you feel as the radiologist that it is suspicious enough that you recommend a biopsy. What are some of the findings that you might see on this diagnostic mammogram or ultrasound that would lead you to recommend a biopsy?
Something that does look like it's a changing asymmetry or a developing asymmetry. There's this kind of cloud-like process that does not go away. So that one I would direct a biopsy, and that one, if it's only visible on mammography, would be called a stereotactic biopsy. Many of the other ultrasound has now replaced the modality we use for the biopsy just by the fact it's easier to position and it's more comfortable for the woman.
So if you're able to detect the abnormality that you see on the mammogram with an ultrasound, then the biopsy you would use the ultrasound
to look,
to direct the needle
and direct
into
numbing and needle into that.
And if you can't see it on ultrasound, but you see it on the mammogram, then that sort of biopsy you use a mammogram to help make sure the needle is
Correct.
in the
It
correct
uses
area.
orthogonal targeting because it's a 3D image again, or at least angled imaging. And the stereotactic biopsy can be done either sitting or laying down, face down. I use it somewhat like a mechanics. It's like, nope, I'm working under the table. You're face down. The table rises.
So again, to repeat what you've already said, 90% of the women who get called back will have the imaging and won't need a biopsy. Then 10% will need a biopsy, but only about 30% of those will actually have cancer. So even if you get to the point that you recommend a biopsy, it's still more likely than not that it's not cancer.
Correct.
Yeah. So now maybe describe a little bit the process, how long it takes, the interaction, how painful, do you numb it up? And maybe describe both an ultrasound directed biopsy or a stereotactic biopsy, which is directed by the mammograms.
By the computer aided. So stereotactic biopsy, as I said, it's like we still do an exact mammogram. So it's repeating what has already been acquired. We would identify the target and use calipers to mark it. And then the computer, it does its own background and it's using angles. So it knows from there how deep and what XY coordinates as well. So
basically triangulation.
It is.
And directs you to where to insert the needle and how far to advance it.
Correct.
And at what angle.
And at what angle. So it can kind of angle based on where it is in the breast, whether it's closer to the nipple or towards the chest wall, which angle I need.
Do you numb it up with?
Yeah. So you create, obviously after it's kind of localized and cleaned off, we'll numb it up with a local lidocaine and deeper lidocaine towards the target, because we have the needle already on the tract and you can kind of see the orientation. I need to numb from here to here. So we'll be able to provide perfect lidocaine. And majority of women say, I didn't feel anything after the lidocaine. Perfect. Lidocaine works.
Yeah.
I like that.
And then what about the ultrasound directed biopsy?
And the ultrasound is more dynamic, just by the fact that we are using ultrasound to guide the needle placement for both the lidocaine and for the procedure. So first we find it, determine the best angle to get at it, and then do the same process. So numb up the skin by a wheel, follow the numbing needle into the target. So I numb up the target again and then take a different needle. The stereotactic biopsy uses a vacuum. So it actually, once I get it in, I don't have to move it in and out again. I just kind of vacuum that target site. The ultrasound biopsy that I have has a spring mechanism. So it actually has a trough in the needle that it sends out first, captures that target, and then covers it. So it sounds like a pop gun noise, or and then I can pull it out and get that sample into the specimen cup.
And then about how long does it take before the results are known, and what's the process at the MercyOne mammography department, breast imaging, for who gets the results and who then informs the patient?
Majority of the times, the patient is aware that they need a biopsy. So we have a navigator that is able to bridge that gap between my interpretation and getting a schedule and talking through all of the concerns that any woman would have. It's like, what do I need to do? What do I need to prepare? And then afterwards, we do send the specimen to our pathology group, and they always return it within 2 days. Sometimes it's 24 hours and I'm getting a result back. My navigator gets a text alert that is available to them, and she can kind of coordinate and call the patient directly with those results, and is able to assist too, that if it is benign, you're done for the year, we may not need anything. If this is high risk or anything more, she can actually schedule the patient for the next visit, which is usually a surgical consult.
Right. So they can, at the time that they're informing them that this is abnormal.
Right.
And would they, over the phone, use the word cancer? This is
usually
breast
well,
cancer.
yes, that this is
But we can
ductal
help,
cancer,
and
lobular cancer, but
and then schedule them right
and
then
then
and
but
there.
we need to kind of get you scheduled.
And I know that's pretty quickly done. Right?
Yes.
I mean, so once you tell somebody you have breast cancer, you don't typically say, and a month from now,
And now
you'll
4 to
see.
6 weeks.
So
No, it's
usually
within that
few
a day or
days.
two.
Yeah.
That they are then seeing a breast surgeon and then coordinating the rest of the imaging as needed.
Okay. A couple of questions about the process. So one would be, when you do a mammogram in the state of Iowa, it's also by law that a patient is to be informed of their mammogram results and is to be told about how dense their breasts are.
Yes.
So talk a little bit about, what is a dense breast? What does that look like? Why do we tell patients whether they have a dense breast or not? And what are the implications for the patients when they get the letter saying you have density A, B, C, or D breasts?
So there are 4 categories of breast density. It has unrelated to actually how they feel. This is only visible mammographically. And so the first is fatty. It doesn't mean that there's flabby. It just means that they have no white lines or white densities that's obscuring things. They're the easiest to read. It's not hiding anything. The next is scattered. So it's going to be kind of snowfall, but not a snowstorm. So there's going to be scattered densities throughout. That is not usually a problem as well. There are 2 categories that are called heterogeneously dense and extremely dense. I'm going to jump to the worst, which is the extremely dense, which looks like a whiteout. There is, I can tell calcifications, I can tell architectural distortion. If there is a mass in there, I may not be able to find it.
So it's like looking for a snowflake in a snowstorm.
It is completely snow whiteout.
Whereas at the other end, the breasts look black.
Yes.
Because that's what fat looks like. And so often a cancer would look like a spot of white.
A whitish.
And so it's a lot easier to see a little spot of white in a black breast than it is to
see
find a
one
little spot of white in a white breast. And by white and black, I mean the way it looks.
Attenuation on a mammogram.
On a mammogram, not race.
Correct. And the heterogeneously dense is just a grade in between. It's got a lot of density that can obscure masses. And the 3D has aided that one the most, because I'm able to go through now stepwise and find between those islands of glandular tissue and see it better.
So we definitely know that women with less dense breasts, mammograms are more reliable.
Yes.
What about does having more dense breast tissue, does that increase the risk of developing breast cancer?
There have been many studies, and it has been statistically shown that if we compare the densest category, D, and the fatty content of A, that there is about a 2.6% or 2.6 times higher breast cancer. But those are the two ends. The lowest end is 10% of the women. The highest end is 10% of the women. Obviously, 80% of people fall right in between those, to scattered and heterogeneously dense. So it's a little less clear how much of an increased risk is in those, but it would triangulate out that, yes, there's going to be some increased risk as well.
So we've talked about mammograms, both screening mammograms and diagnostic mammograms. We've talked about the role of ultrasound. What is the role of MRI imaging of breasts? And maybe explain what is an MRI of the breast and under what circumstances does an MRI of the breast help?
I'm going to step back just a bit because breast cancer detection rate, radiology is number specific. So breast cancer detection rate for a mammogram should be at least 3.5 cancers detected per 1,000 women. Our range is usually around 6 to 7. So we're better at detecting those here in our group. 3D aided that by about 1% or by 1,000. So it's, again, 7-8% or 7 or 8 cancers per 1,000. MRI can detect about 17 cancers per 1,000. It is really sensitive on detecting them. It also overcalls a lot of just background breast enhances too. So it's a sliding scale. It's good, but now we have all these other things we might have to work up that may not be significant in that lifetime. So at this point, we do usually use MRI. We use it for breast cancer staging, so to determine that. But for screening, we use it for those people that are at elevated risk, greater than 20% lifetime risk of developing breast cancer and or dense breast. So at this point, that's helpful.
For screening, it is aided in women who, let's say, have a genetic predisposition, or they have a super strong family history, or they have very dense breasts.
Correct.
Yeah. And then what about the role of MRI in women who have had the screening mammogram, got called back, had the diagnostic, had the biopsy, and now have been told that they have cancer? What's the value of doing MRI in those women?
In those women, particularly if they're on the higher end of spectrum for breast density, maybe not the fatty one, it can detect the size better, the margins better. It can detect actually contralateral or extra cancers that may not have been detected on this original workup.
Right, because when you do the MRI, you always do both breasts.
It's both.
Whereas
correct.
A diagnostic mammogram, you might get called back and you just do one. But the way the technology of the MRIs are, when you're laying, they're done with the woman laying on her belly and the breasts hanging down.
Right, and there are 2 cylinders that the breasts are suspended in that actually have MRI kind of receptors so that we get really good signal through that.
So under this circumstance, we're doing it with a woman who's already had the biopsy. So we know they have breast cancer. So you see more clearly the cancer you already knew is there. You see more clearly whether lymph nodes might be involved. And you also can see whether there might be any other suspicious areas, both in the breast that has the cancer and in the other breast, which we call the contralateral side.
Correct. And then if detected, obviously that may alter planning, surgical and oncologic planning. So we would then work those up in addition.
Are there other breast imaging modalities that you currently use or that you know are being researched as potentially helpul? And so I'll let you answer that, and then I might throw out a few
other phrases
that people might know.
So in alternative to having an extremely dense mammogram, people have been doing whole breast ultrasound, which is helpful to a mild degree to detect things that are hidden in that. The problem with ultrasound, I find, is it's just a morphology. It's just telling me mass. So there's a lot of fibroadenomas, benign cysts, other things that occur in a dense woman's breast. Whereas the MRI is giving me kinetic information. It's telling me this enhances differently than the rest of the breast. So
it has more blood flow.
It's got something else. So that's one of the reasons I'd prefer screening high-risk people with MRI rather than whole breast ultrasound, because the whole breast ultrasound tends to have a higher number of false positive biopsies. We have to work up these lesions, and at least the first couple of years is going to prompt more aggressive intervention. But one of the modalities I've been looking for is, again, this contrast enhanced MRI, is we now have potential modality of contrast enhanced mammography. They take a mammogram image, we give contrast, we take another image,
and by giving contrast,
subtract the two.
Intravenous contrast.
Intravenously.
Gotcha. So you do the mammogram and then you do the contrast intravenously and do another
Repeat
mammogram with the idea that the breast cancer often will take up more of the contrast.
Yeah, the cancer, well, other cancers, well, fibroadenomas, benign masses can too, but they're not usually as much as the cancer proliferation.
And is it a true statement that when you do MRIs of the breast, it's also done with contrast?
Yes. Yes. That is the biggest disadvantage too with MRI, is at time, because it is a long exam, usually around 30 to 45 minutes. Plus it does require IV contrast.
Okay. Just looking at the time, because I want to leave lots of room for questions with from the audience. Do you sometimes find a lesion, an abnormality in a breast that you can only see under MRI? And can you ever use an MRI directed placement of the needle to do the biopsy?
Yeah, good question. Yes, there are examples of enhancement by MRI. It's usually non-mass enhancement. Masses we can usually find, but occasionally it's just this blush in an area that we'll try to look by ultrasound, we'll try to look by mammo, but we can do MRI guided biopsies. It's a longer biopsy time frame just by the fact I need to give contrast. So there's going to be at least 1 or 2 series acquired before I can even begin. But it is still, while the woman is kind of face down with the breast in light compression, but we have an alphanumeric grid on the outside of the breast that then we can then localize the tumor and guide a needle into that spot. So yes.
Okay. And we're not going to go a great deal into breast cancer treatment now, but let's say a woman was found to have breast cancer and underwent treatment, and the treatment was a lumpectomy, breast radiation, and they may or may not have gotten some chemotherapy and some anti-estrogen treatment. What's the process for following the woman after treatment to number one, make sure the cancer is gone, and number two, make sure there's not a recurrence?
Yeah. So obviously with the surgical change, even excisional biopsy or a lumpectomy, you want to get at least the first mammogram as a diagnostic mammogram, meaning I'm going to have the capability of getting extra images to say, is this just related to the surgery or is there something new going on?
Because all that treatment's going to cause changes.
It's going to look different.
Yes.
Definitely will look different. And usually our surgeons will follow the patients at least for 1 and maybe 2 years directly and do those diagnostic exams, because there can be evolving changes.
And sometimes that first year we might do 6 months.
Yes, 2 6-month follow-ups.
Follow-ups rather than annual.
Going directly to
and then after about a year, you get a better feel, because you're always comparing to the previous one, that things have stabilized.
Yes.
And then you feel more comfortable going to once a year.
Absolutely. And then we're looking for obviously the contralateral breast or new changes in that breast, because there can be a recurrence or a new cancer. So that'll show up the exact same way, a new asymmetry, a mass, calcifications, changing and distortion.
Yes. So one of the things, maybe you can elaborate, one of the things you look for is calcifications, but every woman has some calcifications. Almost all the calcifications are benign, but there are certain types of calcifications that are more commonly associated with some types of cancer.
Yes, there are, and they're called intraductal calcification. So the ductal system is arborized from the nipple all the way back in the breast. When I see branching calcification, so it kind of goes in a line, it starts to branch, it branches again, those have a higher prediction of having at least a DCIS, ductal carcinoma in situ component there. There are other calcifications that aren't as easy to differentiate, but then we look for greater than 3 to 5 in a cluster. When they're diffuse, or when they teacup called milk of calcium, there's like microcystic areas that get like sediment to them. Those are benign. So there are some that we can disregard because they do have characteristic patterns.
Is there a role for MRIs in follow-up of women who've had breast cancer treatment? And then maybe speak to the patients who've had mastectomies, or let's say they've had both of their breasts removed, but they've had their breasts removed with a technique where they still have their skin and they still have their nipple, but the breast tissue has been removed. Do we do imaging as part of follow-up for those women?
For follow-up of women that have had lumpectomies, it depends on whether they were under the age of 50 when they first had their cancer diagnosis. If so, then it's an annual recommendation. Or if they're breast cancer survivors that have dense breast tissue, again, going back to that comment, if they're C or D, heterogeneously or extremely dense, they would benefit by doing the supplemental MRI. And usually it's alternating. So a 6-month mammogram and then wait 6 months, get the MRI, come back, do a 6-month mammogram. So the mammograms are 1 year or once a year. The MRI is once a year, but you're getting imaged every 6 months.
And what about the women that had the bilateral nipple sparing mastectomy?
At that point, we don't do directed MRI of them. It is something that is, if something is palpable, obviously it's dermal or just beneath the skin.
Either the patient or the doctor feels
something.
an abnormality.
And then we start with ultrasound because it is the most available modality I have. Would not do a mammogram unless there were extenuating circumstances, like I'm looking for fat necrosis. Then we might do some views, but not a standard mammogram. And MRI isn't usually done on those that have had mastectomies. It's usually pretty straightforward to go from an ultrasound, and if need be, do the biopsy based on ultrasound and then determine what it is.
Okay. And we're talking about other modalities. So you sometimes see advertised for women to get thermo mammograms. What is that, and what's your what do you think of those in terms of using them as a screening mechanism?
And the thermograms made sense perhaps when it was just being proposed, because it's measuring a heat source, and potentially cancers are unregulated, so it might be more metabolically active, produce more heat. Unfortunately, thermograms are a beautiful image that have no diagnostic help at all in any breast cancer detection. No, they are not recommended. They are strongly discouraged.
And then what about nuclear medicine scans? So maybe we'll start with PET scans, but then there's also some gamma
symptomomography. Okay. So yes, a gamma, it's a injected tracer. I'll start that one and go back to the PET, because the PET probably would never be used for screening. But the symptomomography is using a similar positioning as a mammogram, but injected a radioactive tracer, and they found that that also uptakes in breast cancers. So that they put them under light compression, inject that, and do several scans of each breast while it's still being within the blood pool.
So it's kind of like a bone scan for the breast.
Dedicated with a high resolution,
so
kind of a better detector than a whole body detector.
Does the isotope that they use go more to the breast, or does it go to the whole
It
body?
goes everywhere, which is
Gotcha.
its disadvantage. So
Yes.
it's a fairly
Exposing the
a
whole body to
higher
radiation.
radiation dose than
Mhm.
any other screening modality that I have. They've worked to decrease it, and they've made great strides, but
Do you think
I don't
with
think it-
breast MRI, do you think that nuclear medicine test for the breast is has seen its heyday? Is it
it's
becoming less popular?
there are certain academic places that still use it,
Okay.
but I don't think it's going to be widely available in the community. And I don't know exactly why you would want to do a nuclear medicine one rather than the
The
MRI.
MRI, yeah. Okay.
Although MRI has its contraindications. Obviously, if you have a cochlear implant, cardiac pacemaker, you cannot get the MRI.
Gotcha. So it could be
Some aneurysm clips. That's where the contrast enhanced
Right.
mammography, I'm hoping, will replace.
So as we know, and most of the folks in the audience might know, you don't get exposed to radiation when you have an MRI. It's
Mhm.
done with magnets. So the good thing is you're not being exposed to radiation, but if you have any metal in your body, you may not be able to have
May
an
not be a
MRI.
candidate for
Yeah.
the MRI.
Okay. Let's talk about PET scans. So if a woman's been diagnosed with breast cancer, why might they be, why might the physician order a PET scan?
So yeah, the PET scan, traditional one is a glucose molecule that has a radioactive tracer to it. So it's put into the body, and there it goes for the most metabolic sites, which is the brain, the heart, and the GI tract. So there's a lot of uptake throughout the rest of the body, but specifically tumors will usually be avid. Infections are also avid, but the woman probably would not have that active at that point. So then we do a whole body PET to determine that site of involvement or staging
To look for cancer that might have spread
that
from
have
the
gone
breast.
beyond the breast and probably beyond the first site is usually to the axillary lymph nodes, and we often look, or we always look for those when we're staging. But if it had gone to those, gone above the supraclav area, and then there's a couple along the sternum, on the inside of the sternum, called the internal mammary nodes. Some drainage pathways go that direction, so that would be useful to detect those as well.
And it could also detect breast cancer that might have gone to the lungs or the liver or the bones.
Yes, yes.
So many breast cancers are very slow growing. And in fact, the older one is when they get diagnosed, the more likely that's going to be what we call estrogen receptor positive, luminal type A, slow growing indolent. Those don't often show up real well on a PET scan because they're not metabolically active. So there's a new scan, the brand name Syriana, and maybe talk a little bit about that type of PET scan and how that PET scan might be better for detecting metastatic disease in women who have very slow growing breast cancer.
That are ER positive, so estrogen receptor positive. The Syriana is actually an estradiol analog, so it will be on those specific subset of cancers that have the ER positivity. If it didn't, then we'll be back to the usual PET scan. But we can use that Syriana to detect metastatic disease from breast cancer versus potential benign masses or other metastatic foci. So if it takes up by the Syriana, say in a bone lesion or in a lung lesion, then we know it's an estrogen receptor that's marking that.
So instead of a radioactive sugar, you attach a radioisotope to an estrogen molecule, injected intravenously. The estrogen molecule would carry the little isotope to an estrogen receptor positive site of breast cancer.
And that'll aid in those that would be very difficult or sensitive to biopsy. So brain, some parts of the spinal cord, difficult parts of the the body that you really can't even get a needle to adequately.
Gotcha. So you can help determine if that's an estrogen receptor breast cancer metastasis. Let's open up to questions. So we've got our studio audience here. We're going to let our live studio audience have first shot. And if you're watching us live streaming right now, we'd invite you to put your questions in the comments section. And we'll start with you, Poon.
Hi, Boone.
Thank you. What a great presentation.
Oh, thank you for
Of
attending.
course, I have 1,000 questions, but you have answered most of them. So, for example, does Mercy have free imaging at any time for women who cannot afford? Because I get that question many, many times.
We have worked with Bras for the Cause who donate some money, and we do have a dedicated day usually for imaging, muffins and mammos that are for uninsured or very much underinsured women. But we do usually coordinate with the state of Iowa to try to coordinate that more so during the year, because the some of the other monies that they get from the Bras for the Cause. So we'll work with the state of Iowa and the Underserved Network.
Yeah. And I'd also say that through the CDC, the Centers for Disease Control, there is a program, a national program called the Breast and Cervical Cancer Early Detection, Prevention and Treatment Program. The state of Iowa calls that program, which is a long acronym, Care for Yourself. And so that is a program for uninsured and underinsured women. And that also allows women to get mammograms. And it also, for those women who are found to have breast cancer, it expedites them getting to have Medicaid as an insurance to be able then to pay for the treatment. Because it's one thing to pay for a screening mammogram. Just give us a rough cost for a screening mammogram.
I would say it's probably around $250
for a screening mammogram.
for a screening mammogram.
Is that what you get?
And most insurances do cover a screening mammogram, 100%.
Yeah. I would suspect that what you get paid from an insurance company is less than that.
Much less than
Much
that.
than I think it's less than $100. And but I mean, that is a barrier to some people, but it's nothing compared to what it costs to go through breast
Surgery
cancer
and
treatment. So back when the program only paid for the screening mammogram, or not-for-profits only paid for the screening mammogram, it still was a barrier, because a woman goes, well, okay, they're going to pay for my mammogram, but what if they find something? Because I can't afford to pay for treatment. So when they changed the program to allow that if you've got the mammogram done as part of the breast and cervix cancer early detection, screening, and treatment program, you would automatically be able to get the treatment paid for. So, yeah.
Good. Thank you.
Angelina.
Yeah, I mean, I was going through flashbacks as you're describing all those. And
Hopefully
it's
not
like,
bad ones.
no, I mean, I do agree that the biopsy was really great. I mean, yeah, the numbing didn't feel it. Watched it on the screen, and the radiologist doctor's going, did your primary give you something? You're like very calm. And I said, no, I went to church and I prayed and had a priest give me,
That worked.
and I said, so that calmed me down. But I have a question about the PET scan, because I'm a diabetic. So one thing is what you have to watch your blood sugar.
Mhm.
And of course I was nervous and it was high. And they said, the doctor says we can't do it until we can get it down to at least 170. I mean, that's how high it went, up to 210. And I go, yeah, I'm a bit nervous. And was it because of the amount of sugar or glucose that's in that?
And I'm
Sure.
not as knowledgeable about exactly why, but yes, it is the amount of sugar that is kind of already bombarding all of your receptor sites that we putting in, and a little more sugar here, it may not have a sensitivity to detect it.
So Angelina, it's not that you're going to get too much sugar from the IV and the sugar is going to send you into,
No.
it's that the fact that you already have a lot of sugar, it may not pick up this
These-
sugar because
This
you've already
small amount.
got. So it's not that they're concerned that this is like drinking
Gonna
3 Cokes and you're gonna
Go into
increase
a-
your blood sugar. It's that it may not be
Be
as
s-
effective.
sensitive to detect the tracer part of it.
Okay.
I got a quick question. So tonight we talked a lot about imaging, the different parts
Mhm.
of imaging. We talked about breasts that are dense and not so dense. And then you talk about if they're not dense, you can see it very well because it's black.
Right.
If it's really dense, it's all white, right?
Correct.
And you can see that through imaging. Okay, so now we're doing black and white. Do you have any imaging techniques that deal with color? So for instance, if my wife has dense tissue, then you say, okay, we're going to do another one here, but we're going to do it in color. Can that be interpreted into the
Good
procedure?
question. Or obviously, as a radiologist, I deal in black and white. But the color range is usually a CAD, and so it's a computer aided detection, and that's really only in like PET and MRI that can change this value into a true color scale. Mammography at this point does not have anything that is color detected. The 3D, as I said, is my best defense to go through all of this dense tissue by 1 millimeter slices rather than 3 centimeters. So that's still the best defense is.
So
the
Sandy,
3D.
sometimes when I'm looking at ultrasound images in the radiology viewing, there's some color in those.
Yes.
What is
That is a directional flow. So it is actually vascular ultrasound will detect flow and we'll put a color to see if the mass or the area has flow in it. But it is just actually detecting vessels rather than
gotcha. So you
color.
push a button or something and,
Yeah.
and have the computer just use a color to designate where they see blood flow.
Where it's seeing movement, yes.
Okay.
And whether it's going to the transducer or away from the transducer
Okay.
will depend on what color it
Okay.
matches.
George, do we have some questions from the studio audience?
Well,
I
this
mean, from the-
question is for me. Wait,
Good.
yeah, I know you talk about numbers a lot. As a woman in Iowa, what percentage of women in Iowa will get breast cancer? And is this part of this increasing rate of cancers in the state of Iowa? And then maybe the last part of the question is, has breast cancer always been with us? And to what extent do you think it was with us to what it is today?
So the incident of breast cancer and on the U.S. scale is about 8%. So yes, that has a baseline. Iowa, I was just looking up numbers from our state of Iowa. Iowa has the 9th highest rate of breast cancer in the U.S. So we're above average, which isn't a good above average to have. So yes, for some reason, Iowa still does have a higher incidence of cancers, including breast. And breast is the most frequent cancer in women, other than skin cancer. Has it increased? Our detection is picking it up earlier than can be felt, but there is still an ongoing increasing rate of breast cancer despite our early detection methods to try to beat it.
And I'd add a little bit that over time, if we're talking centuries ago, before we were doing screening mammogram, so the advent of screening mammograms, where we were doing imaging of women who don't have a history of cancer and don't have symptoms of cancer, that really increased the incidence of cancer that we would report. So arguably many of the women that before screening mammograms had breast cancer, but we just didn't detect it. And many women have an indolent breast cancer where it's not, you might think, oh gosh, we weren't detecting it, they all died. No, many types of indolent cancer that we detect now the patient might have done fine without it. That's a whole nother topic, is this very, very indolent cancer. So incidence definitely went up when we started detecting, but the cure rate went way, way up as well, because we're now detecting very early breast cancers. And that's the whole reason for having a screening. I would also say that when you look worldwide, breast cancer tends to be more higher incidence in more affluent countries, and that in developing and middle income countries, the cancers that you primarily see that are dominate are infectious disease caused cancers. So worldwide, cervix cancer in women is very, very high, and sometimes is the most common cancer in women in developing middle income countries. Whereas a higher level of income, you get fewer of the infectious disease cancers. So in the United States, there's many, 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 many more breast cancers than there are cervix cancer.
Yes.
So would you say it has something a lot to do with the eating, what's out there? I mean, people are on low income or fixed income can only afford the food that's not exactly good for us. Is that creating that high level of?
Actually,
think-
Angelina, it's the opposite.
Oh, really?
People with high incomes are the more likely to get the breast cancer. And it's because, so worldwide, those developing countries, individuals are usually doing a lot of physical labor, and they're more likely eating off the land, fruits and vegetables and freshly butchered animals and fish. And ironically, what we might have referred to as a peasant diet is becoming expensive in the United States, but we also have lots of Twinkies and yo-yos and Oreos and so the one of the risk factors for developing breast cancer, especially in women after menopause, is obesity, inactivity, too many calories, eating highly processed foods. Those are the things that are more likely, along with taking estrogens after menopause, that increases your risk of breast cancer. But those are the things that are more likely to increase breast cancer in women after menopause.
I know you described quite a number of techniques that you use. That's pretty incredible. And not to get into too specifics, but say a woman has gone through all the procedures and went with a double mastectomy. Following up on that, how do you decide what sort of imaging to monitor?
Good point. And if it truly is a double mastectomy, usually leaving the skin and the nipple intact, if they weren't involved, it is close clinical follow-up. So they still need to be followed by palpation in the area that's got remaining breast tissue, because you can never remove all of the breast tissue. There's some just immediately underneath the skin and definitely in the areolar complex. So, but routine imaging is not very helpful then, because the skin kind of can obscure part of it. So palpation is still the best that we have for that. I mean, if there is something, then we'll go into extra imaging because of it. But we don't usually go looking for these minute areas yet.
So it really relies on the woman doing self-exams and having the doctor do an exam. So anything that you feel that's abnormal we would direct ultrasound or a biopsy, but that just mammography isn't of benefit, and doing whole body MRIs isn't of benefit in detecting something you can't feel for women who've had bilateral mastectomies. And Dr. Ruhs makes a good point that, unlike the kidney, so if somebody has their kidney removed, the urologist who removes the kidney knows I've got the whole kidney out. I mean, it's self-contained, it's got a capsule around it. The breast tissue doesn't have a capsule around it. So when a breast surgeon or plastic surgeon removes breast tissue, there's breast tissue. It's not just one lump with the capsule. It extends under the skin, far beyond what you might think of as where the breast is. So even if a woman has both of her breasts removed, she hasn't had every single breast cell removed. So that's why even after, we call it a risk reduction mastectomy when you have a prophylactic mastectomy, but it doesn't eliminate the risk for breast cancer because you still have some breast tissue left.
Yeah, significantly less and less risk, but not zero.
So, Dr. Sandy Ruhs, thank you for being our guest. We
thank you.
could continue for another hour, but we're out of time.
Yeah, you've got somewhere to
So,
be.
Dr. Sandy Ruhs, the director of women's imaging at MercyOne Radiology Department, and an important component of our cancer center team. Yes, so thank you for being
You're
with
welcome.
us.
Thank you.
And if you're watching this show tonight and you know someone that might benefit by watching this, it will be available on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and also at the MercyOne website. So thanks again for joining us. I hope you join us again next week. Thanks, everyone.